arranged by the Yemeni Neurosurgical Society in collaboration with WFNS, Young Neurosurgery Forum, and Neurosurgery Coach, and Walter Dundee Yemen Student Club, and Neurosurgical TV, and the Pakistani Society of Neurosurgeons. Today, we have two speakers. The third speaker, Dr. Victor, had a conference now, so he will not be able to join us later. Okay. So, Dr. Mujahid. يلا انت بركة. يلا تمام.
I'm not hearing.
يلا دقيقة عندها بعد دقيقتين. So you can start introduce our speakers and then we start.
Dr. Ahmed, you start.
Okay, Dr. Mujahid, you can start to introduce our speaker, our first speaker.
Assalamu alaikum wa rahmatullahi wa jumu'ah mubarakah. For everybody, you are welcome. We will start today with Dr. Mahjabeen Memon, consultant neurosurgeon from Liaquat University of Medical and Health Science. First female consultant neurosurgeon in LUMHS and Hyderabad, with the title of this lecture, Anatomy of the Armpit for the Neurosurgeons. You are welcome, Dr. Mahjabeen, and everybody, you are welcome to this lecture. We can start.
Dr. Mahjabeen.
Yes, I'm here. Thank you so much for this introduction. And I'm honored to be on this platform to be presenting anatomy of the orbit. So can I share my screen?
Yes, Doctor, you can start.
Yes.
Is my screen visible?
Yes, perfect.
And audio is clear?
Yeah.
Okay, should I start?
Yes, it's time.
Yes, you can
it's
start.
Already time, so you can start.
Okay. Assalamu alaikum, everybody. I'm Dr. Mahjabeen Memon, a consultant neurosurgeon working at the Department of Neurosurgery, Liaquat University Hospital, which is associated with LUMHS, which is the institute, Liaquat University of Medical and Sciences, Hyderabad, Pakistan. Today, I'll be discussing something about the anatomy of the orbit for neurosurgeons. So it's a very vast topic, but we'll be focused on the anatomy of the orbit in respect to neurosurgery and its approaches. So to start with, the orbit is a cone-shaped structure with an approximate volume of 30 centimeter cube, and it is a very complex area. It's a very small area, but very complex area. And it comprises of several neural, muscular, vascular, ligamentous, and osseous structures that opens onto the face. So the base of the, if we see, I'm just showing the pointer. The base of the orbit is quadrangular in shape. You can see this. And the apex is triangular in shape, which is formed by the optic canal and the superior orbital fissure. We'll see. The orbit is made up of 7 different bones, and we'll see in the subsequent slides what bones make up the walls of the orbit. The contents of the orbit, as I already told, that it's a very complicated area, and there are a lot of structures fit in a very small space. We have the globe, several important cranial nerves, including the optic nerve and the extraocular muscles, and the nerves supplying the extraocular muscles, the ophthalmic artery and its branches, the ophthalmic veins. So it's a very pretty busy area, and we'll be discussing all of this today. The bony anatomy of the orbit, will start with the roof of the orbit. Basically, there are 4 walls. There is roof, lateral wall, medial wall, and the floor. And then there is an orbital rim and the apex. So we'll discuss one by one. The roof of the orbit is formed by the frontal bone, the orbital process of the frontal bone, and a small part of the posterior of the roof is formed by the lesser wing of sphenoid. This is the roof of the orbit as seen from below. So this entire bone is the orbital plate of the frontal bone, and a small part is formed posteriorly by the lesser wing of the sphenoid. Also, we can see that there is supraorbital foramen, which is on the roof, along the, actually it is in the upper border of the the rim of the orbit, and it transmits the supraorbital nerve. We can also see the lacrimal fossa in the roof of the orbit. The floor is made up by two bones. One bone is the maxilla and the other is the zygoma. So here we can see the floor of the orbit. Here this entire bone is the maxilla, and the important aspect of the floor is this fissure, the inferior orbital fissure, which basically lies between the floor of the orbit and the lateral wall of the orbit. And we can also see this structure, the nasolacrimal canal, which transmits the nasolacrimal duct. Here there is also a very faint groove, which we'll see in the subsequent slides, but we can appreciate a slight subtle groove, which is the infraorbital groove. And this groove allows the passage of the infraorbital nerve, which opens into the infraorbital foramen. Here we can see this is the infraorbital foramen in the face. Infraorbital nerve is basically the continuation of the maxillary division of the trigeminal nerve. The medial wall is one of the complex of all walls because a lot of bones actually contribute. 6 out of the 7 bones that form different walls of the orbit contribute to the medial wall. We can see this bone, the small green bone, which is the lacrimal bone, then this orange bone, which is the lamina papyracea. This is the orbital plate of the ethmoid bone. And this is a paper-thin bone, and it's an important landmark for entry into the orbit when we are doing endonasal surgeries. This is again the maxilla, and this small bluish bone is the palatine, the orbital plate of the palatine bone. Again, this is the sphenoid bone, and this lesser wing of sphenoid contains the optic foramen, and superiorly, a small part of the medial wall is formed by the frontal bone as well. The lateral wall is formed by the greater wing of the sphenoid and the zygoma, and again, to reinforce this concept, that there is a fissure lying between the lateral wall and the floor of the orbit, which is known as the inferior orbital fissure. We'll see that in a minute. The orbital rim is formed superiorly by the frontal bone, laterally by the frontal as well as the zygomatic bone, inferiorly by the zygoma and the maxilla, and medially by the maxilla and the frontal. So this is the basically orbital rim or the base of the orbit. This is another picture to further understand what we have went through so far. So we can see this superior orbital fissure, which lies between the lesser wing of the sphenoid and the greater wing of sphenoid, the optic canal, which is in the lesser wing of sphenoid, the inferior orbital fissure, which lies between the greater wing of sphenoid and the maxilla. And here we can see the part of the orbit which is called the apex of the orbit. The apex of the orbit is comprised of 2 foramina, the optic foramen and the superior orbital fissure. And the bone that divides these two is known as the optic strut. Optic strut is nothing but a bony landmark which arises from the anterior clavicular process and goes on to the sphenoid body. And this optic strut divides the optic canal from the superior orbital fissure. In the superior orbital fissure, we can see a small ridge as well here, which is important for the site of attachment of the annular tendon or the annulus of Zinn, which we'll see shortly. This is an again picture just for an overview. This is the roof formed by the frontal bone. This is the lateral wall, which is formed by the greater wing of sphenoid. And here we have zygoma. Here in the floor, we have maxilla. This important bone, again, lamina papyracea, which joins with the frontal bone with at the level of the frontoethmoidal suture, and these 2 foramina, here and here. These are the anterior and posterior ethmoidal foramina, which transmits the anterior and posterior ethmoidal nerves and vessels. Again, we can see the optic foramen, the suborb fissure, and the inferior orbital fissure. Now, this important structure, the superior orbital fissure, is a very busy area that involves several structures to enter into the orbit and leave the orbit. The superior orbital fissure is formed. This is basically the posterior view. We are looking at the superior orbital fissure from posterior. That is, we are basically right now in the middle cranial fossa, right? So this is the superior orbital fissure. It lies between the lesser wing of sphenoid and the greater wing of sphenoid. A small part is formed by the frontal bone as well, and medially a small part is formed by the body of the sphenoid as well. Again, the same anatomical landmark, the optic strut, which separates superior orbital fissure from the optic canal. This is the anterior clinoid process, and this is the area of the attachment of the annular tendon. The inferior orbital fissure, as we visited previously, lies between the maxilla and the greater wing of sphenoid. Here we have infraorbital groove, again very faint in this structure, but it allows for the passage of the intraorbital nerve. And the inferior orbital fissure opens posteriorly into the pterygopalatine fossa and inferiorly into the infratemporal fossa, as we can see in this picture. The orbital apex and the annulus of Zinn, basically this part, if I can. This part is comprised of a tendinous ring, which is called the annulus of Zinn. The annulus of Zinn basically is nothing but a common tendinous origin for the 4 recti muscle of the orbit. The annulus of Zinn has the optic foramen and the oculomotor foramen. This is the oculomotor foramen. The optic foramen allows for the transmit of ophthalmic artery and the optic nerve. Then this oculomotor foramen allows for the passage of other cranial nerves, as we will see, including the oculomotor nerve, nasociliary nerve, and the other nerve, which is the abducens nerve. We'll see shortly in the subsequent slides. Again, this is the annulus of Zinn, the optic foramen, and the oculomotor foramen. We'll see all these muscles and the nerves in a minute. Again, a simplified diagram. So this is the annulus of Zinn. Here we have the superior rectus, medial rectus, inferior rectus, and lateral rectus. This is the levator palpebrae superioris, but it lies outside the annulus of Zinn. This is a more detailed diagram. We are seeing at this structure, at this level, and this entire tendinous ring is the annulus of Zinn. This is the superior rectus, medial rectus, inferior rectus, and lateral rectus. This is the optic nerve, the ophthalmic artery, and this structure is the superior division of the oculomotor nerve. This is the inferior division of the oculomotor nerve. This nerve is the nasociliary nerve, which is a branch of the ophthalmic division of the trigeminal nerve. And this nerve, obviously, which is going to the lateral rectus, is the abducens nerve. Outside of the annulus of Zinn, now this is a very important aspect to understand, and it's also important for the exam point of view, that the structures that lie outside of the annulus of Zinn are these two nerves. This nerve is the frontal branch of the ophthalmic division of the trigeminal nerve, and this is the lacrimal nerve, which is also a branch of the ophthalmic nerve. Another structure that lies outside the annulus of Zinn is the superior ophthalmic vein and the inferior ophthalmic vein. And this small nerve over here, this is the trochlear nerve that goes on to the superior oblique muscle. This nerve also lies outside of the annulus of Zinn. This is a very important concept to understand. Now, once we've understood the annulus of Zinn, we'll go to the stepwise dissection of neural structures in the orbit. This is the floor of the anterior fossa. And after looking at this, this is the frontal bone. This entire is the frontal bone. Once we remove the frontal bone, we can see the frontal sinus, the ethmoidal sinuses, the sphenoid sinus, and this structure, which is the periorbita. This entire is the periorbita. Once we open the periorbita, this is the reflected, these are the reflected ends of the periorbita. We can see the globe. The 3 important nerves that we can see, obviously optic nerve is on its way. I'm excluding optic nerve. I'm just talking about the nerves that are entering through the superior orbital fissure. The 3 nerves that we see are the frontal nerve, which is a branch of the ophthalmic division, which divides into the supratrochlear nerve and supraorbital nerve, which is faint here. Another nerve is the lacrimal nerve that goes laterally to the lacrimal gland. And this nerve, not to be confused with the nasociliary nerve, because we have the concept that the ophthalmic nerve enters the superior orbital fissure and divides into these 3 divisions. No, the nasociliary nerve, as we saw previously, passes through the annulus of Zinn. So what is this nerve? This nerve is the trochlear nerve that goes on medially to the superior oblique muscle to supply it. We see in the subsequent sections. Again, the same picture, but with labelings. The frontal nerve, 4th trochlear nerve, and the lacrimal nerve. Now this is a clearer picture. Again, the frontal nerve, right? It's going medially, dividing medially into the supratrochlear nerve, and this is the supraorbital nerve. This is the superior oblique muscle. This is the pulley, that is trochlea. We know with which it crosses and attaches to the globe. And this nerve is the trochlear nerve. This is a lacrimal nerve going laterally. The important landmark here is that once we go deeper, there are few structures that cross the optic nerve. This is the optic nerve. There are few structures that cross from laterally to medially above the optic nerve. One of the important structures is the superior ophthalmic vein. The other is the ophthalmic artery. And the third is this important nerve, the nasociliary nerve. And these three structures crosses the orbit from lateral to medial above the optic nerve. If we go further deep, and we open the annulus of Zinn between the superior oblique muscle and the levator palpebrae superioris, we can have this medial corridor, but we have to save this nerve, which is the trochlear nerve. Again, this is the trochlear nerve that we can see. And if we divide the annulus of Zinn between the lateral rectus and the levator palpebrae superioris, we can have this lateral corridor. This is the entire lateral corridor in which we can see the ophthalmic, superior ophthalmic vein, the optic nerve, the ophthalmic artery. But the fact is that we have to retract the superior ophthalmic vein laterally towards the lateral rectus, because if we are going to retract it medially, it will be blocking the access to the lateral part of our field. So this is the same picture zoomed in, that we have opened it between this muscle, that's the levator palpebrae superioris, and lateral rectus. Once we have divided the annulus at this level, we can see clearly the structures that we should be able to know. This nerve, this entire nerve, is the oculomotor nerve. It divides into the superior division and the inferior division. The superior division goes on to supply the superior rectus and the levator palpebrae superioris. The inferior division goes on to supply the inferior rectus, inferior oblique, and medial recti muscles. Also, we can see this nerve, the abducens nerve, which is going to supply the lateral rectus muscle. This is the lateral rectus. Again, this is the ophthalmic artery, the deeper part in which we can see the optic nerve. And this nerve that is passing through the annulus of Zinn, along with the optic nerve and ophthalmic artery, is the nasociliary nerve. The nasociliary nerve is, again, as we knew, that it's a branch of the ophthalmic division of the trigeminal nerve. Okay, this structure is the ciliary ganglion. These are the motor branches from the inferior division of the oculomotor nerve going on to the ciliary ganglion. And this is a sensory branch which goes on to the nasociliary nerve, and it is going also to the ciliary ganglion. Another important structure is this one, this nerve, which is going outside of the annulus of Zinn all the way up to supply the superior oblique. This is the trochlear nerve. And this is the superior ophthalmic. Same dissections with labeling. I think it's clear, but again, we'll have a brief overview. This is the frontal nerve, supratrochlear, supraorbital nerves, fourth nerve, cranial nerve, that is trochlear nerve. This is the lacrimal nerve going on to the lacrimal gland. This is the nasociliary nerve lying deep within the annulus. And then we have the lateral rectus, the superior rectus muscle, the levator muscle, and the superior oblique muscle. If we open the tendon between and we reflect the superior rectus and the levator palpebrae superioris and the lateral rectus, we can see further deep structures. Again, the structures passing from lateral to medial, that's the superior ophthalmic vein, the nasociliary nerve, the ophthalmic artery, and further structures we can see after reflecting these structures laterally. Again, here we have opened the dura of the middle fossa as well to see how these cranial nerves enter into the superior orbital fissure. So we can see the cranial nerve 4, cranial nerve 3, and cranial nerve 6 entering to the superior orbital fissure. We can also see the Gazarian ganglion and the 3 trigeminal divisions of V1, V2, and V3. Again, a zoom in view. Here we can see the divisions of the oculomotor nerve. This is the superior division, and this is the inferior division. The inferior division is important that it gives the branches to the ciliary ganglion. And the superior division, as we saw previously, it supplies the superior rectus and the levator palpebrae superioris. The inferior division give rise to the inferior oblique muscle, innervation to the inferior oblique muscle, innervation to the medial rectus, and innervation to the inferior rectus. A brief overview of the cavernous sinus. The cavernous sinus is the part, and the lateral part of the cavernous sinus is the area from where all these nerves pass to enter into the superior orbital fissure and then subsequently into the orbit. So this is the anterior clinoid process. This is the third nerve. This is the fourth nerve, trochlear nerve. This is the ophthalmic division of the trigeminal nerve, and this nerve is the abducens nerve. All of these nerves, they pass through the superior orbital fissure to enter the orbit, and this is the ophthalmic vein. This is the second division, which goes on to the foramen rotundum, and this is the V3 that goes on to the foramen ovale. If we go further, if we go and have a closer look, we can see that sixth nerve, this is the sixth nerve. It passes all the way from the Dorillos canal and it goes medially to the V1, that is ophthalmic nerve, and then enter into the superior orbital fissure. The same nerves, third nerve, fourth nerve, sixth nerve we already saw, V1 and the ophthalmic artery all the way passing through, not the ophthalmic artery, sorry, but branches of the supracrinoid ICA passing through the superior orbital fissure. So going on to the ophthalmic artery, it provides the major blood supply to the orbit and the optic nerve, and it arises from the supracrinoid artery. It's important not just that it supplies the or optic nerve, but it also supplies the other structures in the orbit, and it provides an important anastomosis between the internal cerebral artery circulation and the external carotid artery circulation. So this is the ophthalmic artery. It goes on to give this branch, which is the ciliary artery, this branch, which is the central retinal artery, and then it divides into the terminal branches, that is the anterior and the posterior ethmoidal arteries, and they pass to the anterior and posterior ethmoidal foramina, as we saw previously in the bony dissection. Further closer views of the ophthalmic artery. This is the ophthalmic artery. This is the branch, which is the central retinal artery, which enters the optic nerve. This is the ciliary artery. And here we can see again the ophthalmic artery going from lateral to medial here, right? And it is dividing into the anterior and the posterior ethmoidal arteries. Again, the central retinal artery, the ciliary artery, and here along with the ophthalmic artery, we can see this nerve, that is the nasociliary nerve. The superior ophthalmic vein, which also crosses from lateral to medial, has been divided. This is the important view in which we can see the central retinal artery here. And it's very important during surgery that we have to take care of this vessel. It's a very small vessel, but once it is involved or it is coagulized or bipolarized, it can result in blindness. So you have to be very careful about it. The venous drainage of the orbit is via two major vessels, major veins. That's the superior ophthalmic vein and the inferior ophthalmic vein. Both of them mostly join, and they form a single stem that drains into the cavernous sinus, but sometimes they can drain separately as well. If we see the front view of the orbit, we can see all of these structures that we have went through. This is the levator palpebrae superioris. This is superior rectus. This is the trochlea, that is the pulley. So obviously this will be the superior oblique muscle. This is the medial rectus, inferior rectus, the inferior oblique muscle, the lateral rectus muscle. And this nerve, which is going towards the trochlea, obviously will be the supratrochlear nerve. And obviously we know that this is the sclera, this is the cornea, and all of this stuff. The brief overview of the orbital lesions. In order to understand the orbital lesions, we should understand different compartments of the orbit. So there are four compartments. There is this intraconal space that lies within the annulus of Zinn, the extraconal space that lies outside of the annulus of Zinn, and then we have the ocular lesions like globe lesions, and then we have the optic nerve sheath lesions. So we already saw, it's just a summary of what is present within the conus, within the annulus of Zinn. These all cranial nerves like optic nerve, oculomotor nerve, nasociliary nerve, abducens nerve, they are within the intraconal compartment, and the extraconal compartment, that is the nerves that go outside of the annulus of Zinn. They are the lacrimal and frontal branches of the ophthalmic nerves and the trochlear nerve. So the lesions can be intraconal, and the intraconal lesions can be either placed situated medially, centrally, or can be either placed laterally, centrally, or medially. As far as extraconal lesions are concerned, they can be present between the muscle and the periorbita. They can be in the orbital wall, or they can be outside the orbital wall. For example, this is an intraconal lesion, an optic glioma that is compressing the globe and it is causing proptosis. So we should know that in intraconal lesions, the proptosis is central proptosis, whereas in the extraconal lesion, like this is a sphenoorbital meningioma, which is compressing the globe, and it is also causing proptosis, but this proptosis is abaxial proptosis. These are the different orbital lesions, and we are not going into the detail of these lesions, just an overview which I gave. The optic nerve is important in segments that we should know a few segments of the optic nerve. There are 4 segments. The smallest segment is the intraocular segment, which is of just 1 mm. The other segment, second segment, is the intraorbital segment, which is the longest segment. It is around 25 to 30 mm in length. The intracanalicular segment lies within the optic canal. It's 9 to 10 mm, and then intracranial segment, which lies within the cranial cavity, it is around 10 to 15 mm. A few words about the orbital approaches. The approaches of the orbit basically can be understood in a way that there are 360-degree approach to the orbit. Like we can have medial orbitotomies, superior lateral orbitotomies, and the inferior orbitotomies. So as far as superior lateral orbitotomies are concerned, if the lesion is very extensive and large, we can go through a pterional craniotomy, we can go through FTOZ approach. If the lesion is very small and laterally located, we can just go through a small lateral orbitotomy. And if the lesion is very small and located just in the roof, we can go through a keyhole approach, supraorbital keyhole orbitotomy. If the lesion is in the floor, we can add additional zygomatic osteotomies that can enable us to reach the lesions of the floor of the orbit. We can go through maxilla to reach the floor of the orbit as well. That's one of the pathways. And for the medial lesions, we have obviously the revolutionary endoscopic endonasal approaches through which we can break down the lamina papyracea and we can enter into the medial orbit. So again, the brief overview of the supine and lateral approaches. If the lesion is large, we can go for larger craniotomies and orbitotomies, but if the lesion is small, we can go through a small lateral orbitotomy. And this is the exposure. This is quite a good exposure that a small lateral orbitotomy can give us. It's a lacrimal gland. This is the lateral rectus, and if we retract the lateral rectus, we can have the view of the entire internal structure. This is again an example of a small lateral orbitotomy that can be done. And again, this view is seen when we do a small lateral orbitotomy. We retracted the lateral rectus above. We can see the optic nerve, the ophthalmic artery, the small nerves along with it. And this is also very small. For small lesions, it's also a very good corridor. But if the lesion is very large and extending superiorly as well as the lateral wall of the orbit, we can go through the frontotemporal zygomatic osteotomies in 1 piece, in 2 piece, or in 3 piece. To the floor of the orbit, we can go via the maxilla, and this is the maxillary antrum. Maxillary, the roof of the maxilla also forms the floor of the orbit, so we can go through the roof of the maxilla as well to reach the floor of the orbit and its structures. The medial wall approaches, as we already discussed, this is the lamina papyracea. These are the ethmoidal air cells. If we enter through the endonasal surgery, we can enter the ethmoidal air cells, we can break the lamina papyracea, and we can enter into the medial wall of the orbit. So this is the lamina papyracea. This entire wall is the lamina papyracea, which is nothing but the orbital plate of the ethmoid bone. And if we break down this, we have a very good exposure of the medial wall of the orbit and periorbita. Further, if we open the periorbita, we have this medial rectus, the inferior rectus, and the superior rectus, and the superior oblique muscles, and we can see globe, the ophthalmic artery, and all these structures that can be seen. Thank you so much.
Thank you very much, Dr. Mahjabeen. Dr. Mujahid. Please unmute, Dr. Mujahid.
Thank you, Dr. Mahjabeen, for this nice presentation. And thank you, Dr. Ahmed, for your good preparation. And we can start now for the second lecture.